Uh, Today we are going to discuss on a very important topic. It's a basic, in fact, when we start taking care of the neonates, something basic knowledge that we need to have, and that is about the temperature maintenance, temperature regulations, and how to manage hypothermia in newborns. And to discuss on this topic, to present this on this topic, we have the team from KEM Hospital, Pune. I welcome the team from KEM Hospital. Dr. Umesh Vaidya, who is the head of the Department of Neonatology. Sir must be busy, but I think he has given two mentors to help in preparation of this topic. So I welcome both of them. And I welcome Aarti Patharkar, who is going to be the presenter for today's session. So warm welcome to the team from KEM. I would like to extend warm welcome to today's two eminent experts who are going to be here to discuss on this topic. We have Dr. Ashwini. Dr. Ashwini is from Dr. Ashwini RC. She is Associate Professor, Division of Neonatology from Department of Pediatrics, JJM Medical College, Davangere, from Karnataka. She has completed her DM from PGI Chandigarh, and she has been serving in Davangere since then. So warm welcome to you. Ashwini, are you there? Hello. Dr. Ashwini, are you there? I can see she has joined. Okay. Yeah, and a warm welcome also to today's expert from the nursing fraternity, Dr. Mamta Verma. Warm welcome, ma'am. She is also associate professor and principal in charge of nursing college at Savitribai Phule Bhavan, AIMS, Bhopal. So yeah, warm welcome, madam, for today's session. So this, just to brief this Noel session, it is basically online education for learning, but it is both teaching and learning which happens in this session. And the nursing students who have joined for fellowship under NNF from all over India are expected to join for this session, and it is not limited only for them. All the nurses who are involved in neonatal care are welcome to join, learn, and as well as share their experiences and join in the question answer session as well for this. So that is the whole motto for this Noel program. I would also like to extend my warm welcome to the committee members of Noel who are over here today. I can see Madam Meena Joshi. She is a co-chairperson for this committee. So welcome, ma'am. And others, Dr. Parul, ma'am, then other committee members who haven't joined, Dr. Kirti Naranjay, Dr. Mahendra Jain. They are not joined over here right now, but in absentia. I welcome all of them for this session, and we will start with the presentation now. Yeah. Dr. Ashwini, you are there?
Yes, ma'am. Sorry, it got disconnected briefly while you were singing. So thank you.
I have introduced already to you.
Yes, thank you, ma'am. Yes, ma'am. Thank you, ma'am, for the
yeah. So over to you, KEM, the team from KEM Pune. Yeah, sorry. Can you, the mentors, could you please introduce yourself?
Yes, ma'am. I would like to introduce Aarti sister as well. So, ma'am, I'm Dr. Sandeep from KEM Pune. First, I would like to introduce about our unit in Pune that we have our NSU here. It is one of the largest NSUs in India. It was established first in 1973, ma'am. And it was established as a 6-bedded unit initially. And over the years, we have the NSU has been transformed under the guidance of our consultants. And currently, right now, we have around 50-bedded NICU, ma'am. And it is already very renowned for its excellent care in preterm and in sick babies. We also have multiple facilities like TPN and respiratory therapist and lactation consultants and other things, ma'am. So in our units, we also have ventilators, HFO and CPAP, which is common to all others. We also have an in-house 2D echo. But I think what differentiates us from other units is that in our unit, a lot of importance is given to increase the learning process of the nurses as well. The nurses are actually very well oriented towards the patient and the uh, relatives. So they actually get a lot of exposure towards the neonatal conditions and how to manage and how to counsel the parents and what advice are supposed to be given when the baby is being discharged. So that these parents who are unaware of how to handle a baby, at least the nurses actually tell them and guide them how to look after the baby. So, and we also have nurses rounds. So once a week, maybe twice a week, the nurses actually present the round to the consultant, and they actually told what differences or like if there's any corrections that are to be made. Also, the nurses also have a in-house presentation in the conference room. So and that is how we help each other learn. So, ma'am, I would also like to introduce Aarti sister. She is our in-charge sister here since many years, and since last 33 years she's been associated with our NICU, and since last few years she's been our in-charge sister. So she has been very dedicated for the past 33 years in our unit. So and for her dedication, I would also say thank you, ma'am. And she'll continue with the presentation. Her presentation today is about hypothermia, and so she will just take over from here. Thank you so much.
Thank you, Dr. Sandeep. Good afternoon to all of you. Today we will discuss about neonatal hypothermia and its management. So neutral thermal environment is defined as a range of environmental temperature in which a neonate can maintain normal body temperature with minimal basal metabolic rate and least oxygen consumption. This is a definition of neutral thermal environment. So we will see in the graph, there is a shown slide in the slide, normal range of neutral thermal environment. It means 36.5 degrees centigrade to 37.5 degrees centigrade. It is a neutral thermal environment, and less than 36.5 to 36 degrees is a mild hypothermia, and in between 36 degrees centigrade to 32 degrees centigrade is a moderate hypothermia, and less than 32 degrees centigrade is a severe hypothermia. If the baby is having severe hypothermia, baby may lead to complications. So if temperature goes up to for more than 40 degrees also, baby may have prognosis. So we should take care of thermal care to reduce the mortality and morbidity. Now you see, what is a hypothermia? Cold body temperature less than 35 degrees centigrade is a hypothermia. So mild, there are three types of hypothermia. Mild, it defines as a 35 degrees centigrade to 36.5 degrees centigrade. And moderate hypothermia is a 32 degrees centigrade to 35 degrees centigrade. And in severe hypothermia, temperature is less than 32 degrees centigrade. Now we will see how to measure a neonate's temperature. There are three methods of taking temperature. First is touch method with back of hand of caregiver at hands and feet and abdomen skin. We can take temperature, we can measure temperature because the back of arm is a very sensational, and we can take temperature. If the baby's hands and feet are warm, it means baby is thermal comfort. If hands and feet are cold and abdomen is warm, it means baby is in cold stress. If the hands, feet and abdomen are cold, it means baby is having hypothermia. This is a second method of measuring temperature by thermometers. This is an ideal method to measure temperature of the baby. Digital thermometers are preferred to take temperature. We can take auxiliary temperature as well as rectal temperature. Rectal temperature is a safe temperature. It is a invasive temperature taking temperature, but it is a safe method. How to place the thermometer? The thermometer should be parallel to the chest wall. This is a correct way of taking temperature, not this one. The other picture is showing that baby is lying on, and thermometer is placed in axilla, that is horizontal. We should not take like this. We should keep thermometer parallel to the chest wall. This is a third method to take to measure the temperature. Thermistor probe is in mainly in incubators and warmers. It records skin temperature. It is available in radiant warmer and incubators. It should be attached on the skin over upper abdomen of the baby. Why newborns are more vulnerable hypothermia? Because they are more prone for imbalance between heat loss and heat production. Why baby is having heat loss? Because of they're having less subcutaneous fat and less insulation. They're having larger surface area, and they are more skin exposed, and they're having thin skin, and blood vessels are closer to skin surface also. Now we will see mechanism of heat loss. There are 4 mechanisms of heat loss. One is conduction due to contact with cooler objects. Then second one is convection due to air current from open window. Evaporation of amniotic fluid from baby's skin. And fourth one is radiation, that is heat loss to cooler objects around the baby wall. If we keep baby on a cold weighing scale, baby loses his weight and baby may get hypothermia. And we, in this, due to air current, if the AC is on, if fans are on, then baby loses heat again by convection. And evaporation takes place if the water evaporates. Thus, the baby loses heat. And in a heat loss of radiation, if the baby's around wall, cold wall is there, then baby gets heat losses. It will be there. How baby produce heat? Baby produce heat in by normal metabolic process at major organs like heart, liver, then brain, and adipose tissues, and also by metabolizing brown fat also. And how baby conserve heat? That is a heat in flex posture. It reduces surface area, and also in peripheral vasoconstrictions, it reduces blood flow to the skin. Now we will see harmful effect of hypothermia. Baby will present pale and mottled skin, then persistent acrocyanosis may be there, and central cyanosis will be there, respiratory distress, then apnea may be there. Baby may have bradycardia or lethargy. There will be poor muscle tone or weak cry and weak sock also. How to prevent hypothermia? Prevention is better than treatment. So we have to care about the hypothermia. It starts from the birth only. So what we will do, what is to be done in the labor room? We have to keep delivery room warm, that is a more than 25 degrees centigrade, and free from drafts. The AC should be off, fans should be off, and windows should be closed. Turn on the radiant warmer 20 to 30 minutes before birth, before taking baby in the warmer. So receive the baby in pre-warm sheets. As soon as infant is born, dry them immediately to remove amniotic fluid. Baby should be covered in warm blankets. Then skin to skin contact should be given to baby and mother. And we should encourage early breastfeeding. Occlusive plastic wrap. It is used for all babies less than 32 weeks. Baby should be covered, the preterm baby, with plastic wrap immediately after birth without drying. It reduces evaporative heat loss and it allows radiant heat delivery, and it improves NICU admission temperature of preterm babies. In warm transportation, we have to continue to monitor temperature, and we should ensure warm transportation, and incubator should be used for all preterm babies. In NICU, we are using incubators and warmers. So we preferred over radiant warmer for preterm babies less than 32 weeks. There are two modes. One is air mode and servo mode. Air mode temperature of environment around the baby is set, and servo mode desired skin temperature is set to 36.5 degrees centigrade to 36.8. All sick babies should be kept under servo mode. In radiant warmers, it is a open care system. Preterm babies more than 32 weeks are being kept under radiant warmers. There are two controls. One is servo control and manual control. We have to start with manual mode with 100% heater output before keeping the baby, and then switch to skin mode 36.5 degrees centigrade to 36.8 degrees centigrade when baby is placed under the warmer. We can also use cling wraps that reduces invasive water loss. We should use plastic wraps or cling films. Now we will see things to be done in postnatal ward. We should keep the PNC room warm, cover the head and the extremities with appropriate clothing, use socks and mittens for the baby, nurse the mother and baby in the same bed. Skin to skin contact should be given to baby and mother. Then we should promote breastfeeding. Kangaroo mother care can be given to the baby for standard. This is a standard method of care for preterm and low birth weight babies. We have to place them in skin to skin contact with mother. One of the many benefits in reduction in hypothermia by ensuring thermal comfort of the baby. So we will see, we have seen up to here that what we have to do from labor room to till the PNC ward. We will see now management of hypothermia. If hypothermia occurs, then what we have to do? We will see next slide. So cold stress or mild hypothermia management. Remove all cold wet cloths. Eliminate all mechanisms where it can be lost. That is, open window should be closed. Then AC draft or weighing scale should be weighing scale of cold weighing scale. We should cover adequately with warm clothes to the baby. That is head cap, mittens, and warm blanket. We should not let the baby open like this. Then we should ensure skin to skin contact immediate after birth with the mother. Continue to monitor the temperature of the baby half to 1 hourly till 36.5 degrees centigrade, then hourly for 4 hours, and then 2 hourly for 12 hours. Now, moderate hypothermia management. We have to provide additional source of heat. Rewarm the infant by using warmer, incubator, warm towel, face changing mattresses. We have to attach skin probe. That is, we have to take on servo control and we have to maintain constant temperature. This is a heated water mattress and we have to monitor the temperature of the baby. In severe hypothermia, we should manipulate baby immediately, then rapid rewarming immediately using radiant warmer and incubator till 36 degrees centigrade, then slow rewarming to 36.5 degrees centigrade. If the glucose is below levels, we should start the glucose. And if oxygen saturation is decreased, we should start oxygen immediately. Now, when to report to doctor? If glucose is low, then we have to inform to doctor. Then we should initiate feeding and we should start glucose. If the respiratory status is respiratory distress, tachypnea, if the baby is having retractions, nasal flaring, or oxygen saturation is dropped, baby is having apnea, we should provide warm humidified oxygen and prepare for further support for the baby. Parents counseling and family teaching. We have to teach the parents how to take the temperature, what is the normal range of temperature. Then caution them to not overheat baby, avoiding over bundling and over dressing their baby, especially while sleeping. They should not over bundling the baby. Do not dress up more as per the seasons. They should they should be informed that when baby is crying, excessive cry may be there, they should inform to doctor. If baby is quiet and not taking feeds, then also they have to show to doctor. They should inform to doctor. Take home message. Hypothermia is a common neonatal condition. It can be prevented by small steps by the healthcare provider and mother, which results in a better outcome. Vigilance and intervention at the correct time have proven to be beneficial. Preterms are more prone to get hypothermia. Then appropriate care helps increasing survival rates. Covering of baby and KMC plays a vital role in prevention of hypothermia. Keep warm and grow on. Thank you, ma'am. Thank you all.
Yeah, thank you, Aarti, for that excellent presentation. Yeah, so now I open the discussion with the experts. I invite the experts to start with the discussion. You can ask any questions or whichever point has not been covered, we can discuss on that, or any points which you would like to make sure that the viewers have understood. We can discuss on that as well. So Dr. Ashwini.
Yes, ma'am. So I think Mrs. Aarti, that was a very good and crisp presentation, and it was quite informative. So a good job on that. I would like to, like, as you have already mentioned, what is the importance of thermoregulation and the importance of maintenance of thermoneutral zone for neonates, because that is one of the biggest handicap. So can you, just tell me what is the handicaps that the preterms especially have? Like term babies also have some handicaps, but preterm neonates is where we are more concerned of the problem of hypothermia. So can you just elaborate a few handicaps that the preterms have?
Yeah. Means so preterm babies may get apnea, hypoglycemia because of hypothermia.
No, what I'm asking is why the preterms are more prone for hypothermia? Why
because
are
there is adipose issue?
So less of brown fat?
Brown fat.
Yeah.
Yeah,
Then?
lack of brown fat. Yeah.
Yeah. Apart from that? So what we know is the skin maturity is also gestational age dependent. So they have thin skin. The stratum corneum is not really well formed. So they are more prone for epidermal heat loss. Evaporative heat losses are more. So because of the thin skin that they have, lesser brown fat as you mentioned, and all newborns we know do not have shivering thermogenesis. When we feel, we shiver, right? But these babies are not able to have the shivering thermogenesis, and for during thermogenesis, they need the brown fat, which they are having less. Okay. So these are some of the handicaps that the preterm babies have, right? So apart from that, I would like to know that and you've had a great service of 33 years. So in your unit, do you practice humidification in incubators for the preterm babies, especially the ELBW babies?
Yes.
Okay, so what is your practice generally for less than 28 weeks, less than 1 kg babies? How much
Yeah.
humidification is being done?
Yes. 80.
80%. Yeah,
80%.
good. Yeah. So again, humidification is one more practice to prevent, you did mention one slide on prevention of hypothermia. So humidification of the incubators is one more strategy that we use, especially in the extremely low birth weight babies or the micro preemies that we tend to, nowadays more and more of micro preemies deliveries are happening. So 70 to 90% is the range in which we maintain these babies in the first week of life. And as their skin matures, we start reducing the humidity by 5% to come to the ambient humidity based on at what sea level we are. Like Pune might have a different humidity compared to Bangalore, or Belgaum, where Manisha ma'am is. So every place will have its own humidity. So we'll have to come down gradually to the ambient humidity. So this basically will help in the reduction of the evaporative heat losses. Okay. And one more thing is practically I would like to know. So we nurse these babies either in incubators, or many units are now practicing managing these babies in radiant warmers only. So how will you know that once this baby is on full feeds and a mother is able to feed the baby herself? So how do you know from a thermoregulatory point of view that this baby is now ready to be clothed fully and moved to the cradle and will be able to maintain his or her own temperature in the normal range?
They are having a normal O2 saturations and O2 saturation and tolerating feeds well. They don't have temperature, maintaining temperature. They are maintaining temperature also. They are able to maintain temperature.
Yeah. So normally what we do, we manage babies in servo controlled mode, right?
Servo controlled warmers.
Yeah. So we once we are seeing that the gestational maturity has come and baby, as you said, is otherwise hemodynamically stable on full feeds and in servo controlled mode to maintain that 36.5 degrees temperature that you have set as the target temperature. If your incubator or the radiant warmer, okay, the baby is able to maintain that without generating any heater output. The ambient air temperature is being maintained by the baby himself or herself without any heater output requirement. So that time, very objectively, you can say that from a thermoregulatory point of view also, this baby is ready to move to the cradle with appropriate clothing. Okay, so we can start with 2-layer clothing based on the ambient temperature that is needed for the baby and the season that we are in. So 2-layer to 3-layer clothing is what the baby requires to maintain the normal temperature. Okay, and I just would like to highlight why we, especially in the neonatal intensive care unit, whether it is the nurses or it is the doctors, we are so very fanatic about the thermoregulation. Mainly, I want to highlight that every 1 degree drop in temperature increases your incidence of late onset sepsis by 11%, okay, and mortality by 23%. So this is something that thermoregulation is something that we need to take very seriously and ensure that no baby has hypothermia. Okay. Thank you, ma'am. Those are the questions from my side.
Yeah, thank you, Dr. Ashwini. For starting the discussion. Yeah, I request Mamta ma'am. you have got any questions to ask?
Rather question I would like to discuss with all the participants and Madam Aarti, since she has a very huge experience and very expertise in newborn care, especially thermoregulation. Let us discuss, Madam Aarti, about the personal hygiene or the sponging of the baby, nappy changing. So we are doing, nurses usually does it on daily basis. Even in we all shift, we are performing it. So it just came in my mind that how do you maintain the temperature when we are cleaning the baby or changing the nappies? What are your usual practices in order to maintain or keep the baby warm when we are doing sponging and changing the nappies?
All babies are under warmer only by changing diapers or giving sponging. All are under warmers only, and heating process is going on. We don't means of that warmers means if, and under warmer only. They are quite means maintaining temperature. They maintain temperature under warmers. We don't off that button, switch off. We continue to care under warmer only.
Okay, and what are your usual practice of skin care of the newborn babies? It is per shift or per day?
All means all your linen and all once in the day we used to change, and for 3 shifts just wipes out means with the with wipes only we are means giving sponge bath, means nothing like a warm water, and we are not using like that, just wipes we are using. Yeah,
Yes,
ready-made
like,
wipes.
I am
Yeah,
curious, like
wipes.
per shift cleaning would be good or per day cleaning would be good, or it depends upon the necessity.
Baby's condition, baby, if baby is soiled, that time we have to do. Otherwise, we don't want to disturb baby and all.
Okay. There is another follow-up question that could you just tell us to the audience how we can maintain the thermoregulation while we are transporting to a newborn from one place to another place, especially neonatal transportation?
While
Just
transporting
key
from
points.
labor, yeah, from labor room, we use clean wraps to the preterm babies and less than 32 weeks. Otherwise, we are using transport trolleys. We are having that transport trolleys. That is a pre-warm transport trolleys are there.
Okay. And the last point of discussion with you, Madam Aarti, I think the parental empowerment is very important. And since your topic is very important, thermoregulation. So as a nurse, what we should points we should discuss to the parents, especially to the maintenance of the temperature when we are rooming in or when we are giving discharge to the newborn babies. Could you just highlight some of the points so the participant can be benefited?
We counsel parents about the clothing as per the environment. Means if winter is there, we have to put socks, mittens, and warm blankets. The baby should be means wrapped. Swaddling should be there, and if it's a summer day, then don't overwrap the baby. You should maintain temperature. We used to tell them. That's. And they can take KMC also, that small babies can be given KMC also. At home also they can give KMC. About KMC, we used to tell importance of KMC also. We used to tell them they can give KMC at home also till up to 2 kg. Yeah.
That's it. Thank you, Ma'am Aarti. Thank you so much. Over to Dr. Manisha.
Yeah, thank you. Yeah,
Dr.
Aarti, can you, yeah, Madam Meena, I'm coming to you.
Okay, I just want to add some
Yes.
corrections regarding the degree of temperature. So we call it severe hypothermia when it is less than 32. Aarti, you correctly mentioned it, but there is slight correction. You said that body heat hypothermia is 32 to 36. It is not 32 to 36. It is 32 to 35.9 degrees centigrade. And then the mild hypothermia, again slight correction, it is 36 to 36.4. So 36.5 to 36.7 is 37.5 is then your normal range or normal range of temperature. One more thing I want to add. There is slight difference in the treatment. How do you treat severe hypothermia and moderate hypothermia? Key points in the management. Aarti, can you just summarize what is the main difference between severe hypothermia treatment management and moderate hypothermia management?
Moderate and severe hypothermia, we use means directly baby placed under the heater warmer, and heater means we have to set temperature at 38 degrees centigrade, and if the baby is having means needed oxygen saturations are dropping, we have to do give supply of oxygen, and we should start IV fluids also if baby is hypoglycemia, and baby can we can initiate feeding also.
Okay, very nice. So in severe hypothermia, we have to be very careful that we have to do rapid rewarming till 34 degrees centigrade and then slow rewarming, start oxygen and maintain IV fluid. And the second thing is give injection vitamin K if the baby has not received it in the labor room or previously. And then you have to ensure a warm room, that is 25 to 28 degrees centigrade. Then you have to monitor blood glucose, and then you have to reassess the baby after every 15 minutes. You see, whereas in moderate hypothermia, you do blood glucose monitoring, but rest of the thing like vitamin K, IV fluids, and sugar monitoring, all the vitamin K, IV fluid, and oxygen. This is done in severe. So this is the main difference. Like in moderate hypothermia, we don't jump into the oxygen, IV fluids, vitamin K. We only monitor blood sugar, and then we rest all is the same. Okay. So now just one last question. Do you know about warm chain? And can you just mention 10 steps to prevent neonatal hypothermia, which we do in warm chain?
Warm chain is after birth, soon after birth, baby, soon after birth, that 10 steps are there. Means first one is room temperature of the labor room should be 26 degrees centigrade, and then we should give if baby needed resuscitation, we should warm resuscitation should be there. Then immediate drying of amniotic fluid, and baby should given skin to skin contact, and breastfeed should be initiated.
And postpone bathing, appropriate clothing, keep the baby with the mother, warm transportation, training and awareness. So these are the 10 steps of the warm chain. Rest you covered, but I just want to add one more thing. Whenever you are covering hypothermia, do not forget to include hyperthermia. Just one slide of hypothermia, and what is the temperature range of hyperthermia, what are the signs and symptoms of hypothermia, and how you will differentiate whether a baby is having hyperthermia because of the malfunctioning of warmer or because of the disease condition. So these are just practical related things. Rest you covered everything very well. That's all, Dr. Manisha. Just so, okay.
Go ahead.
If baby is crying excessively, baby's color may get redness, and baby may have tachycardia. It means something has happened to the baby. We should see what is happening. Baby's temperature should be taken at that time. Baby may have hypothermia at that time. This little signs are giving that baby may have hypothermia.
When we very rightly said, when we work at the bedside, and most of the time we just after KMC or breastfeeding, we place the baby back to the warmer, and we forget to attach skin probe to the baby, and we nursed it in servo mode. This will cause overheating, and it will be very dangerous for the baby. So always make sure that you nurse a baby in servo mode while the skin probe is attached. Otherwise, the skin probe will keep on detecting the air temperature and keep on overheating the baby. So it is very, very important, and it is very, practical related scenario. So it is very important. And never give antibiotic thinking that the baby is having fever or baby is having, infection. So just look for the cause why the baby is hyperthermic, and then you have to treat accordingly. Yeah, that's all.
Yeah, thank you, Meena ma'am. Yeah, just Aarti, we know that kangaroo mother care is one of the best methods that we follow to protect children from hypothermia. Yeah, so can you just elaborate for the audience how does KMC work? How does KMC keep the baby, help to keep the baby warm? And what is the difference between how KMC works and how if the baby we keep the baby under the radiant warmer? What is the difference in temperature maintenance?
Under warmer, babies are kept servo control warmers. There is a set of temperature in means KMC. Skin to skin contact is there, mother and baby, and thus the temperature is maintained. Thermoregulation is maintained by skin to skin contact, and baby and mother bonding is there, and mother feels better to take baby, and love affection is increased, and baby is having a weight gain, and weight gain is there, then early discharge may be there, then early discharge, and it is a cost effective also, KMC, of course, because of weight gain and early discharge, and it cost effect also it is this. And mother feels actual involvement of baby care, means she feels better in KMC, by KMC. Yes.
Yeah, good. I mean, you have covered all the benefits of KMC, how it works. But one of the important things we also need to remember how KMC works is, can you go back to that slide where you showed all those ways of methods of heat loss, conduction, convection?
Yes.
Yeah. So the way the baby loses heat, the similar way baby will gain heat also. Okay. So
Yes.
what will happen when the baby is on skin to skin contact with the mother? So baby is in direct contact, not this one. Yeah, this one. Yeah.
Yes. Okay.
So you have shown here, no, by conduction, when the baby is in contact with cool objects, baby is losing heat. Similarly, when the baby is on direct skin to skin contact with the mother, baby will gain heat also from the mother. Okay. So, these are the ways we need to remember the radiation. Baby loses heat that way, and baby will gain also heat that way. That is how the radiator works. Okay. That is a source of heat for the baby. Okay. Convection currents, conduction. So when the baby is in it, but the way KMC works is like, if the baby is under the radiant warmer, and if we monitor the baby's temperature over there, we will see lot of it will be more of a wavy form. Okay, the temperature will go up and down, up and down. It will not remain stable at the temperature that we want. Whereas in case of when the baby is in KMC, baby is with the mother, the baby's temperature is more stable. It will remain uniform. Okay, there will not be changes, ups and downs changes in the temperature. What this helps, why is that we need to maintain the temperature in one this? What happens if there is what is it that leads to a baby not gain weight if the baby remains hypothermic for a long time? Even for example, mild hypothermia. Okay. Even if suppose, especially low birth weight babies, if the baby remains chronically cold in the postnatal ward or even at home, mother doesn't realize that the baby is has got mild hypothermia. Baby has what is that, cold hands and feet. Okay, so what is the effect that will have on the baby because of this chronic mild hypothermia?
Metabolism of food to energy may not be there, and that's why the baby cannot gain the weight.
Yes, very good, very good. So what baby will do basically, baby wants to maintain its temperature, right? So baby will increase its metabolic rate to create more energy to stay warm. Okay, and that will utilize all its glucose, all its oxygen, and the baby in the whole bargain, what will happen is baby will not gain weight. Okay, So that is what we need to remember, and that is something which we really need to stress on when we tell the parents when they're taking these low birth weight babies home. And I think even you all are in the best position to tell this to the mothers, not even the residents or the consultants, how to keep a baby warm, how to recognize the baby is in getting cold, and what is the importance. So especially just to know why something should be done or why something should not be done, if we tell the parents what is its effect in the long term. Okay, so that is what is important. So if we tell that to the mother especially, she will make sure that she recognizes that the baby is getting cold, and then she takes proper actions at home, okay, to keep the baby cool. What about while bathing the baby? What will we tell the mother if the baby, she has to bathe the baby at home? Okay, what precautions she should take?
Till 2.5 kg, we don't allow them to give bath. Till that, we can tub bath should be given. Means after 2 kg only. Otherwise, they have to do sponge bathing only. Sponge, they have to give sponge. After 2.5, they can give bath. Like this instructions we are giving to the parents or mother.
Okay, and then the mother wants to know what should be the temperature of the water, how she should give bath to the baby. So many questions will be there, no? And they must be asking you all these questions.
Yeah.
What do you tell them? Yeah.
We have temperature. We have to check with the back of our hand. We should check water temperature, and lukewarm water should be used for the bath after 2.5 kg only. We don't allow them to give such a clear bath like that. Till that, tub baths should be given to the baby. Yeah.
So overall, what we need to advise the mothers is, of course, it starts after 2.5 kilo. That is the general this guidelines which are followed. And especially when it's a winter season or rainy season, even if when it's cold, they should ensure that the room is warm where they are going to give bath to the baby. The baby shouldn't be kept naked for a long time. The bath should be very quick using the lukewarm water. And then after that, the baby should be dried thoroughly and then wrapped up completely. So it is important to ensure that the baby doesn't remain wet for a long time. Even simple things like, when we are teaching, especially as a first-time mother, when we are teaching her to take care of a low birth weight baby at home, when the baby passes urine stool, why it is important to immediately change it. Okay, so because mothers don't realize, so it is not just for the sake of hygiene. Hygiene is equally important to give, so that you keep the baby clean, but also for that baby will become hypothermic if the diapers are not changed after the baby passes urine. So that also needs to be stressed on. So these small things have to be told to the mothers when they're taking a low birth weight baby home. Okay, and then according to the temperature at home, how to keep the baby warm. When to use the sets of the layers of clothes, how much to be used. So that is to be told, because one of the most important questions the mothers want to know is how to keep the baby warm, because here they see in the hospital that the baby is being kept in the cradle, some extra warmth is being given to the baby, right? So they always have the question that how we will keep the baby warm at home. So what you will tell them, how to keep the baby warm at home?
Yeah, they can, so baby can, proper clothing should be there, means socks, sweater, mittens, and cap should be there for the baby. And room should be kept warm. And
what do we mean warm? Again, these are the things which the mothers need to be told. I know mothers who just sweat themselves out because they have been told to keep the room warm.
No, if winter is there, that time they should keep room warm. Otherwise, they don't have to keep room warm.
So what should be should can they use heater in the room? If she's taking a 1.5 kilo baby home.
No, they don't. We tell them do not means fans directly on the babies.
Good. Yes, that's very important.
And AC should be off. Like that, we used to tell them.
Okay.
Yeah, and
Yeah.
the windows should be closed. If nearby a baby and windows are coming, means on that draft is coming on baby, so it should be closed. Like that, we used to tell
So
them.
these lot of practical tips should be given to the mothers, and they have a lot of questions. Okay. Otherwise, the mother herself will be sweating and the baby would be sweating and she wouldn't know what is right, what is wrong. Baby would be irritable. So temperature maintenance is one of the what is that? I would say a challenging part when you are sending a low birth weight baby home. And for that 1 month till the baby reaches 2.5 kilo, and after that baby is sort of capable to take care of its temperature, till then what to do during that period is something which is very important to counsel the mothers. We cannot just take it for granted that they have known it or they have understood it. Okay. Otherwise, then they come back with a baby who is not growing and who is irritable, and mother is exhausted of taking care of a irritable baby. So that is what you see in the follow-up clinic then. Okay. Yes. Yes. Anything else you want to discuss, Dr. Ashwini, Mamta ma'am, Meena madam?
Yes, ma'am, I would like to highlight one more thing. For example, for thermoregulation, we talk of warm labor room, receiving the baby, keeping the baby warm transport. And in the NICU, again, with respect to thermoregulation, are again ambient temperature, incubator, radiant warmer, servo control mode. So we take care of all these things. But very important, one more thing which we should not forget is there is a heat loss through respiration also. Heat and water loss happens through respiration also. So if a baby is on respiratory support, right? So the humidification and the keeping the temperature in the right range, right? So what is also called as warmidification. So keeping your respiratory support, the circuit temperature should be like 37 degrees centigrade and relative humidity of 100%. So maintaining that is also very important, because if it gives cold gases.
Yeah, Dr. Ashwini, your connection is not there, I think. We can't hear you.
Asked you, Mrs. Aarti, regarding KMC. I think, ma'am, just like how servo control is there for our incubator or our radiant warmers, similarly, the thermal synchrony in KMC. Body temperature, there is a synchronization that has 0.5 degree colder. So mother's body temperature will increase by that much to maintain the baby's temperature in the normal range. And similarly, if the baby temperature goes up, the mother's body temperature will cool down by that much. So this kind of a synchronization physiologically happens when the baby is in KMC. Okay, so I just wanted to bring across that point.
Okay. Yeah, thank you, Dr. Ashwini. There are a few questions in Q&A box, so we'll just look at that. Lot of answers being given by a lot of participants. Good. I can see Gayatri, you're very active. Lata. Then Helen, yes. And there's somebody who has asked a question. How can we maintain humidity while transferring, or we don't look for humidity while transferring neonate? Okay. What do you want to say about this, Aarti sister? What do you do during transportation about humidity?
While transporting, humidification may not be there. If we use transport incubator, it is possible, but in our setup we don't have that, and humidification is not possible. If we use transport when incubator, I think it is possible.
Yeah, Dr. Ashwini, you wanted to say?
And for far distance, we can. Yes.
The transportation, if it's like a in-hospital transportation, humidification is not very important. So
Yes.
it can be just, transported in the appropriate temperature range. So humidification does not play a very big role, because city to city transfers, intercity transfers are not very common place, like long distance, I'm telling. Short distance transports do happen, but many of them either come in embrace device where humidification is not possible. So for transport as such, humidification doesn't play a major role. Just maintaining the temperature during transport is very, very important. But after that, in the NICU, humidification for ELBW babies in the first week of life, it should be done. And then thereafter, it can be reduced to the normal ambient temperature. Generally, if you do for the general humidification of preterm babies, we say a humidity level of 40 to 50%, which is the general environment humidity level. So at that, it is generally maintained. But for transport, it's not very important.
Yeah, thank you, Dr. Ashwini. Yeah, so others who have answered questions in our Sister Margaret, Kanchana, Vani Anand, Rashmi, Helen. Okay, Helen has mentioned about how they do changes in the humidity. And okay. So there are no more questions which have been asked. Yeah, a lot of people have answered the questions which have been asked during the discussion period. Yeah, so that was a nice discussion regarding temperature maintenance for the newborns. Just to be, I think Dr. Ashwini had mentioned about it. What is the importance of hypothermia when we talk about the outcome, neonatal outcome? Okay. How much it will increase a very drop in temperature by 1 degree Celsius. It will increase the rate of neonatal mortality as well as the chances of infections in the newborns. So that is what we need to remember. And the important thing is just like how what Meena madam asked earlier. Who had asked? Mamta madam had asked earlier. Okay, during our total care of the baby, what you all do, no, the all care of the baby, like cleaning the baby, sponging the baby, changing the diapers, or any other care that you are doing for the baby, even during those moments, it is important that we maintain the temperature of the baby, we regulate the temperature of the baby, and ensure that the baby doesn't become hypothermic during that care also, because it is pretty stressful for a baby who is small, 1 kilo, 1.5 kilo, at least till the time they are 2 kilos. Those drops in temperatures by 1 degree Celsius up and down also is very stressful for them. And and nobody but it is a nursing staff who are capable of ensuring that the baby, protect the babies from hypothermia. So that is the message which really needs to go in today's this discussion. Anything else, Meena ma'am, that we need to discuss?
So I just want to add, like from nursing point of view, okay, humidification for very extreme low birth weight baby, like in AIMS, it depends. We generally avoid humidification because of the risk of growth of pseudomonas. And even if what type of water you are using, sterile water, distilled water, and adding acetic acid to prevent colonization of organism. So it is the best practice is minimum things should come in contact with the baby. But yes, when it is of course unit protocol. So when you are doing it, make sure that you are changing it on every after every 24 hours. The water in the humidification chamber is to be not to be refilled, but is to be completely empty, cleaned, and then again filled.
Yes, thank you. Mamta madam, you want to add anything?
No, I don't wanted to add, but I just want to discuss about the monitoring of temperature through rectal route. I think it's an absolute practice. Nobody practices nowadays. We just check the temperature through axillary route. That's it. But since you have mentioned in your presentation, so I'm just curious whether you are practicing it or you are not doing. No,
we are not practicing.
Okay.
Yeah, we are taking axillary temperature.
Thank you, ma'am.
Yeah. When we measure the temperature, when the baby is under the warmer, where do we put the sensor and why? Sorry, have you discussed that when you presented? Because I don't know whether I missed it. Where do we put the temperature probe when we
Yeah,
are
it should be,
the
it should
temperature?
be placed on right hypochondrium. Yeah.
Okay, yeah.
And,
Okay.
if the baby is prone, then back of the spine means a bit lower side. It should be placed on plank. Yeah.
Okay,
If
yes.
baby is prone position, and if his baby is supine, then it should be attached to hypochondrium, right hypochondrium. Yeah.
And why? Any reason? Do we know?
Because there is no fleshy part is there, and no bones means temperature can be easily recorded. That's
So the temperature probe should never be placed on the bones. Okay, it should
bones.
never be
Yes.
placed on the bones. And it is when we put it in the right hypochondrium, it is close to the liver. Okay, and the liver is the most, it is very well perfused by blood. Okay, so the temperature which we pick up from there, it is much more close to the core body temperature. All right, like what we are trying to do by checking rectal temperature. Right? The same way when we put the baby supine, we are put it somewhere closer to the where the kidneys are. Okay, so we are putting the probe where it is in all the organs which are very well perfused. So we are trying to get as close to the core body temperature. Okay, what is the difference between the peripheral temperature or the skin temperature and the core body temperature?
If the peripheries are cold and abdomen is warm, it means baby is having a core temperature. And if we take temperature means invasive temperature should be taken at time, means rectal temperature should be taken at that time. Otherwise, we can say if abdomen is warm and peripheries are cold, baby is in cold stress, like that we can come to know.
Okay. Yeah, so basically the peripheral temperature, that is skin temperature, will always be lesser than the core body temperature. Okay, 0.5 to 1 degree Celsius. If it's more than 1 degree Celsius, then there is something wrong, because it is one of the things that we look at if the baby is going into septic shock also. All right, so that is one of the indicators that we look at if the temperature difference is more. So basically, yeah, we don't need to go too much into details of that, but what we need to remember is the peripheral, that is the skin temperature, what we are looking at. It will be always lesser than the core body temperature. And the core body temperature, so when we are measuring, we are trying to go as close to possible to the measuring of core body temperature. And that is why those are the placements where we place the thermometer sensors or the auxiliary thermometer, wherever we place it is for that reason. Okay. Right. Anything else we need to discuss? Parul ma'am, you are there?
Yes, thank you, madam. And it was a very good presentation and excellent discussion on the topic. Just to ask one question to Arti. You are practicing KMC for the low birth weight neonate. As in one sitting, how much time mother will spend for the kangaroo mother care, for keeping the baby warm and not to do the maximum handling? In one sitting, at least.
If mother wants to give more than 1 hour, she should not give less than 1 hour, but she can give more than 1 hour. How much time she wants to take, as we can give KMC for the babies in our unit. Many times she comes and goes. We used to tell her that no less than 45 minutes to 1 hour. It should not be less than. At least maybe
1 hour.
minimum
And in
1 hour should be
24
given.
hours. In
Yeah.
24 hours, how much maximum KMC should be given? In 24 hours, how much kangaroo mother care should be given to get maximum benefit?
As much possible, ma'am. As much possible. She wants to give.
How much you are practicing in your unit?
Ma'am, we are having 12 hours, at least 12 hours.
At least 12 hours.
Yes,
So mothers
we
are
have
coming
done.
for how many times? Or continuously mothers are remaining?
No, she goes for eating and like that. Just And while feeding also, we can give KMC, means she is just eating and we can give feed. She wants when how as much as possible time we gives KMC for the baby.
She
We have
can
done
do
like this.
more than 12 hours also, but at
Yes.
home, whether KMC will be continued after discharge, yes or no?
Yes, yes, yes.
And there, how much hours they can practice if the mother-in-law can help the mother.
Yes,
Help
they
the
can
mother
give
to do
mother-in-law or any other family members can give KMC to the baby. Yeah,
Yes.
if she is working, any family members, KFC, father can give, grandmother, father, mother, all can give.
So they
KFC.
can give total 24 hours. 3 persons can give total 24 hours. Okay,
No,
yes
no.
or no?
24 hours, it is not
Not
possible.
24 hours is not possible, except the feeding time and other.
Yeah, feeding
So
time,
maximum
changing time.
duration, more than
Yeah.
18 hours can be done. So how
Okay.
long the kangaroo mother care can be continued at home?
Till up to 2 kg or 2.5 kg.
2.5 kg.
Yeah.
And when
Till
it will be
baby-
discontinued, other
Uh,
than what criteria, is there any criteria to discontinue kangaroo mother care at home? Even at
Yes,
the
after
neonatal
40
care units?
after 40 weeks means if the baby's weight gain is there
40
and baby
weeks,
may not be
2.5, other than these two conditions,
yeah.
if baby is having some discomfort, like baby is crying or flushing or wriggling, then the baby can be, the mother can discontinue the kangaroo mother care. Yes or no?
Yes,
Okay.
ma'am.
Achha, what thermometer you are using, digital or clinical?
Digital thermometers we are using.
And during weight taking, whether you are placing the baby naked, like in this picture, during weight recording, how you are placing the baby on the weighing machine, on the tray of the weighing machine, like in that picture, the baby is placed naked. Whether you are placing naked,
Where on
you are not getting my question.
weighing scale, on weighing scales.
During weight recording, weight measurement,
I can't hear, ma'am.
बच्चे का वजन लेने का टाइम अपने बच्चे
Okay.
को फूले नंगा करके वेट लेते हैं और बच्चे को कवर करके लेता है, लाइक इन दिस पिक्चर डायरेक्ट
Naked.
कांटेक्ट,
Naked, ma'am.
नेकेड,
Yes, naked with not diaper. There is
Not
no
diaper.
diapers. Yeah.
then
Bedside. We used to weigh the babies near their beds.
near their beds. Oh,
Yes.
so you have to take precautions to prevent loss of it during weighing also.
Yes.
Yes or no?
Immediate checking of weighing. Weight should be checked immediate. Yes. Baby should not get cold.
Or you can keep one seat on the baby and then
Yeah.
you can deduct the weight of the seat. Yes or no?
Yes.
You can keep one seat on the tray and then you can make the weighing machine 0 and then you
Yes.
place the baby and then with
Yes.
that seat you can cover the baby.
Yes.
Yes or no?
Yes.
So that precautions you have to, if you are taking,
Yes.
keeping more time naked on the weighing machine, there can have chance of heat loss.
Yes.
Okay,
Yes.
thank you. Good presentation, excellent presentation. Thank you.
Thank you.
Thank you, madam. Yeah, so if there are no more questions or if, yes, Mamta ma'am, anything else you want to discuss?
Sorry, ma'am, another questions. Is you Arti, are you aware that the digital thermometer, what is the lowest recording temperature and what is the highest recording temperature in the digital thermometer?
30 degrees centigrade.
As in centigrade,
Yeah.
yes. How much? What is
30
the
degrees
lowest?
centigrade, we have to get thermometers, digital thermometers of low reading.
Low reading. What is the
Yes.
lowest? What
Lowest
thermometer you are using?
Yeah.
What lowest temperature is showing in that thermometer?
It
Yeah,
is
she says 30 degree, madam.
30 degrees
30.
centigrade.
Yeah.
Yeah,
In India, the commercially available thermometers are not giving recording less than 32.
ma'am, we are
Like
asking for that.
heat thermometer
Yeah,
is having lowest 32.
yes,
So it is difficult to record the severe hypothermia with the simple thermometer, digital thermometer, because that's the lowest recording of the majority of the digital thermometer is 32 degrees centigrade, lowest recording. Radiant warmer can record up to 30 degrees centigrade. So if the continuous there is in the thermometer, it is showing L means low continuously. That means the temperature fell to record the temperature of the body temperature of the baby. Then you have to attach the thermistor probe of the radiant warmer on the baby's right upper abdomen or on the right hypochondriac region to get the exact temperature. Very low reading thermometer is available, that is up to 25 degrees centigrade. I don't know whether if you are having, you can record. But ordinary thermometer can, like Higgs, I am sure Higgs and Amron, those two thermometers are showing the temperature, recording the temperature up to 32 degree only in the lower range.
yes.
So to detect severe hypothermia, you have to be very careful, especially those are outborn baby.
Yes.
Those are in the winter season, in the outborn baby, so you have to be very careful. Okay?
Yes,
Okay, thank you.
Thank you, ma'am. Yes, Mamta ma'am, you wanted to add something? Please unmute yourself. Please, you are muted. Yeah.
Okay. No, ma'am, I don't want to add up anything. Rather, the today's presentation has enriched me. That's it. Thank you.
Thank you. Thank you. So I think with that, we will come to the end of today's discussion. I thank the team from KEM, Aarti, her mentors, and especially Dr. Romesh Vaidya to present this today's topic. It was a little short notice that I had given. But yeah, so thank you for preparing time and presenting. Thank you, Aarti, and good presentation. Well done, and all the best for your future as well. And I'm sure you will be, you are a big pillar of support for that NICU and helping to save more and more sick and small newborn babies. I thank today's experts, Dr. Ashwini and Dr. Mamata for being over here, and not just for the questions, but also for the discussions and sharing your knowledge and experience with all the students. Thank you to our members, Meena madam, Parul madam, they are always there for all the sessions, and the questions they ask, it shows the experience that they have had in taking care of the newborns for last so many years. So thank you for being over here. I thank all the students who have joined and who have been participating very actively. You have been putting up your questions also, and putting up answers as well to the questions which have been asked by the experts. So thank you, all of you. And last but not the least, thanks to National Neonatology Forum for giving this platform for the students to present these topics, which gives them confidence, which makes them learn about the topic, and then gives them good exposure to the experts from different parts of the country, as well as it's good teaching and learning session as well. So thanks to National Neonatology Forum for that, President Dr. Praveen Kumar sir and Secretary Dr. Bisht. And thanks everyone for joining.
Thank you for the opportunity, ma'am. It was a joy, and I think it was a very good presentation and good discussion. Nice to see even the Q&A session, lot of nursing staff answering very quickly. and correctly. So it's always a joy to teach the nurses because they are the backbone of our NICU. So really thank you for this opportunity to be a part of their learning session.
Thank you, Ms. Ashwini. Okay, thanks, Mamta ma'am. And thank you, everyone. Bye-bye.
Thank you, ma'am.
Bye.
Bye. Thank you.
Bye.